So whenever there is a liver disease in pregnancy, we should realize that it carries sequelae, the maternal and the fetal. So in the fetus, there can be preterm delivery, placental insufficiency, nutritional deficit, fetal growth restrictions, distress, fetal bradycardia, fetal meconium strained amniotic fluid. The long-term risks to the fetus include risk of congenital malformation, stillbirth, and intrauterine death. Maternal implications of liver disorders include infection, nutritional deficit, hemorrhage because of coagulation factor deficiency, placental abruption, acute kidney failure, and subcapsular hematomas. Long-term maternal risks may be severe, like neuroglial impairment, psychosocial stress, disease recurrence, and subsequent pregnancies, and mortality in pregnancy has also been documented because of liver disorders. So, to classify the liver disorders, we can tell it can be jaundice, which is peculiar to pregnancy, which include the intrahepatic cholestasis, which is also called as obstetric hepatosis, which is recurrent in 50 to 60% of cases. It can be severe preeclampsia, eclampsia, HELLP syndrome. It can be acute fatty liver of pregnancy, which is also known as acute yellow atrophy of liver. It can be severe hyperemesis gravidarum, or it can be endotoxic shock, as happens in the puerperium sepsis in septic abortions. Now, in the jaundice, which is unrelated to pregnant status, it can be viral hepatitis, it can be gallstones with pregnancy, it can be drug-induced hepatitis with pregnancy due to isoniazid phenothiazine. Then there can be hemolytic jaundice in pregnancy related to mismatched blood transfusions, malaria, Clostridium welchii infection, etc. Sometimes pregnancy can be superimposed on a chronic liver disease like pregnancy with chronic hepatitis, pregnancy with cirrhosis, and pregnancy with carcinomas of the liver. Now, there are some diseases of the liver which can be induced by pregnancy, which can be pre-existing liver disease which can be worsened by pregnancy, or they can just be coincidental with pregnancies. So, induced by pregnancies include hyperemesis, preeclampsia, eclampsia, HELLP syndrome, acute fatty liver of pregnancy, intrahepatic cholestasis, and liver rupture or infarction, as happens in cases of HELLP syndrome with subcapsular hematomas. So, these are the liver disorders which are induced by pregnancy. Some liver disorders are worsened by pregnancy, and they include the hepatitis B, C. Wilson's disease is also worsened by pregnancy. Chronic liver cirrhosis and portal hypertension gets worse with pregnancy. Autoimmune hepatitis, primary sclerosing cholangitis, and primary biliary cholangitis can also get worsened with pregnancies. But Chiari syndrome has also been shown to have an increased incidence with pregnancy. Cholelithiasis is also common with pregnancy. Among the viral hepatitis, hepatitis E is common and fulminant with pregnancy. So this is a diagram, very important one, which shows the origins of this liver disease. So it can be originating in the fetus because of the deficiency of the long chain coenzyme A acyl dehydrogenase enzyme in the fetus. So there is a dumping of long chain fatty acids in the maternal circulation, and which leads to the acute fatty liver of pregnancy. So a genetic defect in the fetus can cause maternal liver disease. So this problem is called as acute fatty liver of pregnancy. Now, because of the problems with the progesterone causing smooth muscle relaxation and a slow enterohepatic and a slow biliary motility, there is an increased incidence of cholelithiasis with pregnancy. There is also intrahepatic cholestasis of pregnancy because of the enterohepatic circulation is compromised. There is also primary biliary cirrhosis and sclerosing cholangitis, which are the ductal defects. There can also be hepatocellular damage in the form of preeclampsia, eclampsia, HELLP syndrome, hyperemesis gravidarum, autoimmune hepatitis, Wilson's disease, and liver cirrhosis. In the inferior vena cava and the hepatic vein, sometimes there is a prothrombotic state which gets exaggerated due to the increased thrombotic state of pregnancy, and this is called as the Budd-Chiari syndrome. Now, normal pregnancy also is associated with changes in the liver chemistry. So, bilirubin may slightly decrease in normal pregnancy. Aminotransferases are unchanged, prothrombin time is unchanged, alkaline phosphatase, which has got a placental origin or a increased synthesis in the fetal bones, increased 2 to 4-fold. Fibrinogen increases by 50%. Globulin by increase in alpha and beta globulin are increased in pregnancy. Alpha fetoprotein shows a moderate rise, and alpha fetoprotein is risen more in multiple gestations. WBCs is rise, ceruloplasmin level increases in pregnancy, cholesterol levels increases 2-fold in pregnancy, triglycerides increase in pregnancy. There is a decrease in gamma globulin, and hemoglobin decreases because of the hemodilutionary effect of pregnancy. Now, these are the parameters like alkaline phosphatase, which is increased, alpha fetoprotein is increased in pregnancy, AST remains normal, total bilirubin within normal or slight decrease, ALT normal, GGT normal, prothrombin time remains within normal limits, APTT within normal limits, thrombin time within normal limits, serum albumin is decreased, total protein is also decreased, and serum bile acids also remain within normal limits in a normal pregnancy.